Hello, you're listening to Genomic Matters. 1 in 2 of us will receive a cancer diagnosis at some point in our lifetime, so it's never been more important to improve the care and quality of outcomes for people affected by cancer. Throughout this series of podcasts, myself and other guest hosts will be speaking with professionals about genomics, genomic medicine, and the embedding of both within routine healthcare. In this episode, I speak with Professor Jim Hill and Marie Kirwan to find out more about the Lynch Syndrome project and what this means for people and families who are identified as having the genetic condition. Okay. So, hello, Jim and Marie. Thank you for joining me today. My name's Barbara Coleman. I'm the comms lead for the Northwest GMSA. Can you first introduce yourselves and your role within the Alliance? Over to you, Marie.
Hi, Barbara. Thanks for asking us here today. So my name's Marie Kirwan and I am the genomic lead nurse for the Northwest GMSA.
That's fantastic. And Jim?
Yeah, thanks. So I'm Jim Hill. I'm currently Deputy Medical Director of the Northwest GMSA. Prior to that, I was a surgeon, a colorectal surgeon at Manchester Royal Infirmary. And we had a long interest in patients with Lynch syndrome, really going back about 25 years. So that personal involvement with patients with Lynch made me realize very much how important it was to establish this diagnosis for the patients and for their families. So I've had a passion about this condition for a long time and very pleased to continue that interest in my role with the Genomic Medicine Service Alliance in the Northwest.
That's fantastic. And say thanks very much for joining me today. So obviously, I'm aware you've both been working really closely on the Lynch syndrome genetic testing pathway. So, can you tell me and the listeners a little bit more about it? And I'll come to you first, Jim.
Yeah, thanks. So this diagnosis, this condition has been known for a long time, but it was really only in 2017 when the National Institute for Health and Care Excellence, NICE, recommended that all patients with colorectal cancer were tested for Lynch syndrome using a couple of different techniques. One is looking at the slides of the cancer under a microscope, and the other was doing a genomic test called microsatellite instability. And then 3 years later, in 2020, NICE also recommended testing for Lynch syndrome in patients who are diagnosed with endometrial cancer. And endometrial and colorectal cancers are the two commonest cancers that patients with Lynch syndrome can get. And for endometrial cancer testing, it was specifically using immunohistochemistry, which is looking at stain slides under the microscope. And then 2 years ago, the National Genomic Test Directory for solid tumours and rare inherited disease went live. And that means that clinicians in England can look the directory up and determine which genomic tests are available to them for testing their patients. So that's been another important development as well in this process. And following the launch of the National Test Directory, local multidisciplinary teams, that means the teams looking after patients with cancers, particularly colorectal and endometrial cancers, can now request genetic testing for eligible patients diagnosed with those cancers. And that's important because it means that we'll be more improved testing, quicker diagnosis, and support and timely treatment planning. And all this is part of a more long-term plan for the NHS long-term plan, which has an important ambition that by 2028, which is not that long into the future, 3/4 of all cancers will be diagnosed at an early stage. And one of the ways this ambition will be achieved is through targeted screening and personalized surveillance of those who are most at risk of developing cancer, such as those with Lynch syndrome, which is the most commonly inherited cancer predisposition syndrome. And that's similar to the BRCA mutation, which predisposes patients to breast cancer. So if we can identify a cohort of patients who we know are at increased risk of cancer, that will certainly help with the NHS long-term plan of identifying patients with cancer at an early stage.
That's fantastic. Thanks, Jim. And so, Marie, over to you from your perspective on the project.
Yeah, thanks, Barbara. So, yeah, as Jim's alluded to, Lynch syndrome is a rare condition, and our project is aiming to improve the early detection of cancer, and from that, be able to access to personalised care for people with Lynch syndrome. So how we're going to achieve this is by embedding a standardised and equitable testing pathway for Lynch syndrome across the northwest of England and wider nationally across England. And it's monitoring and addressing those geographical variations in testing and supporting the development of the infrastructure that we need for testing and expanding pilot testing and assessing these benefits for patients. Identifying patients who have Lynch syndrome means that they can be monitored from a much younger age, meaning that tumours could be caught sooner. And the important thing is that if this happens, treatment would be more effective. So this really is about improving patient diagnosis, prognosis and outcomes. And the Lynch syndrome genetic testing pathway itself will improve the standardisation of the genomic testing, and that again will ensure that we've got equity of access for our patients who are diagnosed with mainly colorectal and endometrial cancers.
Fantastic, thank you. So moving on, so obviously, you've mentioned a couple of times there sort of the mainstreaming of Lynch syndrome testing. So again, from your perspectives, what does that look like? Obviously across our region in the northwest, but also nationally as well, for patients and professionals alike.
So, as Marie's mentioned, effective testing really is the key to supporting and enhancing patient care and ensure patients get the right screening and treatment. It's estimated that about 1 in 300 of the population have Lynch syndrome, but to date we've only identified about 1 in 20 or 5% of patients have got an established diagnosis of Lynch syndrome. The way it's inherited is that a patient passes it on to approximately half of their children of any gender. That means that Lynch syndrome is both a genetic and an autosomal dominant condition, and it's caused by an inherited mutation of what's called a pathogenic variant in one of 4 DNA mismatch repair genes. These are called MLH1, MSH2, MSH6, and PMS2. And these 4 genes are involved in making sure that when DNA replicates, it does so faithfully. So if there were a defect in one of the 4 genes, then the DNA repair defects are not repaired properly. And if that causes a mutation in one of the cancer regulation genes, such as cancer suppressor genes, that increases the risk of people developing cancer. And the cancer they can develop are bowel cancer, particularly colorectal cancer, womb or endometrial cancer, ovarian cancers, and also some other rarer cancers can develop. And so the Lynch syndrome project enables us to think about specific patient groups with specific forms. And by that, we really mean specific biological types of cancer, as we've said, particularly colorectal and endometrial, to increase awareness and identify risk factors before cancer has had chance to develop. And it's worth mentioning, Bob, that in addition to around the patients with Lynch syndrome, that and Lynch syndrome causes around about 4% of all colorectal cancers in the UK, that around another 10% of bowel cancer patients have a similar biology but arises spontaneously and is not caused by a genetic defect. And some of the treatments that are now available for Lynch syndrome, particularly immunotherapy, is also applicable, can also be used to treat the other 10% of patients with a similar biology. So understanding the biology of Lynch syndrome has been really important in improvements in colorectal cancer care.
That's fantastic. So Marie, again, from your perspective, how do you feel? Sort of, what does mainstreaming? I suppose, what does mainstreaming with Lynch syndrome mean to you?
Yeah. So, well, nationally, testing now for Lynch syndrome for both colorectal and endometrial cancer has actually increased from around 25% and has now exceeded our target of 90%. So this is supporting the identification of cancer and the risk of cancer. And this actually meets the NHS long-term plan's ambition to diagnose cancer at an earlier stage. Because as we know, if we can diagnose cancer earlier, it improves patient outcomes. So, if a healthcare professional believes that their patient may be at risk of developing Lynch syndrome, for instance, a strong family history of cancer or family members diagnosed with cancer before the age of 50, then they should be recommending that that patient agrees to a referral for genetic testing and genetic counselling. We would never do genetic testing without the genetic counselling due to the implications of the findings. And it's this process that supports the development of a family tree so that we can actually plot where the family's inheritance has come from, as Jim alluded to. It's passed down in an autosomal dominant manner. And it's this family tree that helps identify these associated risks for other family members, that they can be identified. So it's much more than just a single patient. This is the effects onto families and the wider family members.
It's so interesting, isn't it? So ultimately, from listening to obviously your responses, that improving cancer prevention through identification is a key aim. But can we test for multiple cancers at once, Marie?
For bowel cancer, it was already recommended that everybody be screened for Lynch syndrome. And, there was an established Lynch syndrome testing pathway in place.
That's fantastic. Yeah. So, because again, Jim, I was going to say, Jim, but from your perspective, again, can we test for multiple cancers at once?
So this particular project, Barbara, is looking really solely for patients with Lynch syndrome. And we're testing patients who've already got cancer, which will help with their treatment, but also it's identifying it for families so that we can hopefully prevent other family members from either developing cancers or identifying those cancers very, very early. There are some exciting developments in the world of genomics, which perhaps will be able to identify multiple cancers, and these are going to be, I think, in blood tests. But at the moment, if you actually increase the sort of range of tests that you get, that increases the cost, the workload, and the time to get the results. So this specific project is looking solely for Lynch syndrome. But as I say, there are rapid developments within genomics which are clearly going to allow us, we certainly hope so anyway, for earlier diagnosis of cancer. But the Lynch project is specifically for colorectal and endometrial cancer. But if these patients do develop rarer types of cancer, some of the treatments in Lynch syndrome with immunotherapy are likely also to be beneficial if the patients developed additional cancers.
Thanks, Jim. So what obviously over sort of the 12-month period of the project, what sort of challenges and obstacles have you encountered, Jim?
So what's been particularly pleasing to me and I is the enthusiasm that the clinical teams have shown to actually get the testing up and running in their particular areas. Pathology departments have historically not been particularly well funded, and a particular issue in this project has been agreeing models of testing, but particularly employing the biomedical scientists who are necessary to help with the and who've got the necessary skills to do the initial testing. So that has been somewhat of a challenge, but importantly, the Lynch syndrome project comes with money, so at least the money is available to employ the necessary people. So there have been one or two challenges we've had to overcome with infrastructure and personnel, but overall, there's been a fantastic enthusiasm for all parties, really, Barbara, to actually get this test up and running in their particular areas.
Because ultimately it leads to improvement in treatment for patients, doesn't it? So are patients sometimes worried about finding out that they have Lynch syndrome, and obviously that the implications for that has for themselves, but also, other family members, potential causing distress to them?
Yeah, absolutely, Barbara. It's a really big deal to find out that you have a genetic condition that could increase your own risk of future cancers, but also being made aware that other family members may also be at risk. But when a patient is referred to the clinical genetics department, they would be offered genetic counselling, and genetic counsellors are a distinct professional group with the essential skills, and essentially their work involves finding out which members of the family would be eligible for what we call cascade testing. So this is after the initial family member has been diagnosed with Lynch syndrome. We are then able to offer the family members cascade testing. And this is where, once you've had that, what we call the index case, the initial person with the genetic condition, we can then roll out the test into their at-risk family members. And in this way, it's, we can find healthy people with Lynch syndrome, and hopefully that would prevent future cancers developing because we'll be able to put them under surveillance.
So that's reassuring, isn't it? Sorry, Jim, over to you.
If I could just come in, Barbara, to say traditionally that patients with suspected genetic conditions have all been referred to regional genetics department. But another important element of the Lynch project is to try to get the consent and the counselling that Marie's talked about for the initial genetic test done in local departments, in endometrial, in gynecological and colorectal departments, so that the testing is done locally. And the term that's being used for this is mainstreaming. And once the result of the genetic test is known, the patient would then be referred up to the regional genetics departments for the further counselling and cascade testing that Marie has talked about. But certainly, as genomic testing becomes more common, we're all going to be using genomic tests more, and so the consent and the counselling is going to become a skill that's acquired by many more clinicians for genomic testing.
So to sum up, and again, thanks ever so much both of you for your time. I think it's been really informative to be able to have this conversation. So in your opinion, saying in sort of a sentence to sum up, so what is the future of Lynch syndrome testing, genomic testing for Lynch syndrome? And if you could leave our listeners with a sentence to sum that up in relation to the project, what would that be? I'll come to you first, Jim.
So knowledge really is king when it comes to Lynch syndrome. Mainstreaming will ensure that more patients and their families are identified as having an inherited risk of developing cancer, but we'll be able to determine that, identify those cancers earlier, and treatments, outcomes for the cancer will undoubtedly improve as a result of that.
And Marie?
Yeah, so building on what Jim's explained, as the genomic lead nurse for the Lynch project, it's really heartening to know that by upskilling and developing particularly our nursing workforce, to be able to have the skills and the ability and the capacity to be these genomic conversations with patients, to encourage them to undergo what we call mainstreaming Lynch syndrome testing. It really will be leading to more cascade testing for family members, and just enable that diagnosis of Lynch syndrome and identifying risk, finding healthy people with Lynch syndrome who can then adopt preventative measures will ultimately save their lives.
Thanks very much for listening, everybody. There will be future podcasts in this series, so please revisit our website or follow us on our social channels. Thanks again.